Today we have Dr. Rowe presenting on interventional procedures. This has always been a fascinating lecture to me. It really just shows how many more tools there are in our toolbox as far as getting that pain under control outside of medication management. So with that, I will pass it on to Gretchen.
All right. Good morning, everyone. Everyone can hear me okay?
Yep, you're good.
Good. All right. Well, let's get started. Yeah, it's a topic that I was my topic for a fellow lecture when I was a fellow, and I've been able to give it ever since. So um, very fun to see how it's developed over the years because our institution didn't do a lot of interventional procedures in the beginning, but with hiring of more interventional proceduralists and just a lot of collaboration. It's developed over time. So I have no disclosures, objectives of what we're going to be doing today by the end of this lecture. I hope that you'll be able to explain why interventional procedures should be considered in palliative medicine and why to consider them early. Just, that you'll be able to describe indications and the risk benefits for common interventional procedures, explain which procedures are preferred for different types of pain syndromes, and then be able to identify when neuraxial blocks and infusions could be considered as part of your palliative care toolbox. So a lot of the procedures that we'll be talking about are related to cancer-related pain. So I'll give a little bit of the statistics on cancer pain and prevalence. The prevalence of cancer pain is about 55% for those receiving active cancer treatment, 65% or more in advanced disease, and up to 40% in cancer survivors. It can be related to the cancer itself, metastases, the treatment, or comorbid conditions. There's undertreatment of pain. The undertreatment of pain is higher for underrepresented populations. Actually, I'm going to go back to that slide a little bit more for the prevalence and background. Everyone's probably familiar with that World Health Organization step ladder. I used to have it as one of the slides, but it's starting with Tylenol and adding adjuncts and then opioids. And then sometimes interventional procedures are considered as like a fourth or a higher rung on that ladder. We know that opioids are known to be first line for moderate to severe cancer-related pain. I want to challenge the model of the interventional procedures are that if all else fails, and there's sometimes when you do want to try conventional therapies first, there are times when interventional procedures will be considered much earlier. And so we'll talk about when that may be. And so we know that with opioids being more the first line in moderate to severe cancer pain, we also know that there are significant risks and side effects and impacts on quality of life with escalating opioids. So what other options do we have for refractory pain? Which brings us to our topic today, indications for interventional procedures for pain management. So here's some indications that have been published in articles. Cancer-related pain refractory to traditional opioid pain management despite increasing medication dosing, significant dose-limiting opioid adverse effects, coexisting comorbidities that preclude safe use of opioids. So this could be someone's intolerant or unable to take opioids. They may have an opioid use disorder. There's been prior benefit from a specific interventional procedure for pain management. So these are things to consider. So what are the benefits? First and foremost, pain relief. If it's effective, great pain relief. You can, if it's effective, you can decrease the systemic opioid requirement and therefore the side effects related to opioids. And we're now very familiar with those, as you've probably seen them in your patients, could be cognitive impairment, nausea and vomiting, constipation, respiratory depression, to name some of them. We can improve function. This is huge. If we can not just add more opioids and maybe more sedation, if we can block the pain without increasing opioids, we may be able to improve their function in a different way and therefore improve overall quality of life. There's also evidence to show that it can reduce medical costs, having interventional procedures appropriately used. So now we're going to this is a flashback to July, some types of pain, and just refreshing on this because this may help us when we're talking about the different procedures and what types of pains they help. So we have the nociceptive pain. So your somatic pain is injury to the somatic tissues, bones, joint, muscles. That's more localized. And then there's visceral pain. That's that injury, compression, just invasion of visceral tissues, so the bowel, liver, other organs, pleura. That's more poorly localized. And then you have your neuropathic pain that we see in about 20 to 40% of cancer pain syndromes. So during this lecture, we're going to talk about 3 different categories of blocks. We'll start with sympathetic blocks, then go to peripheral blocks, and then we'll also talk about some neuraxial blocks and infusions. And then after that, just a little extra on neurospine type of procedures that are being performed. So in this lecture, there's a lot of information. I want you to think there's some things I will point out that could be board related that you really should know. And then there's other blocks and things that you'll see that you may not remember, but you can go back to this lecture. You'll have the slides. You'll be able to use this as a reference. I use my own lecture as a reference. I'm like, I think there's a block for this. And I go back and look. So again, not everything has to be memorized, but just if you know that there potentially could be a block for something, you're more likely to send a referral, and then the specialists are the ones that they will figure out which block
No,
would
that
be
was great.
effective. But there are some times when if I know what I'm looking for, I may put that in the referral, and it sometimes speeds things up. All righty. So in this lecture, I'm also going to share the evidence for different procedures if I have evidence for it. And in the references, there's review articles where they went through some of these evidence levels. So there's evidence levels 1 through 3, 1 being the best with more possibly control the randomized clinical trials, and 3 with less evidence. And then the degree of recommendation going from A all the way to there's an I for insufficient. All right, so we're going to talk first about sympathetic blocks. So when you think of sympathetic blocks, think of visceral pain. So that's the afferent input traveling along with autonomic nerves, and the sympathetic blocks interrupt these afferent fibers. So it also can concurrently block sympathetic fibers, which leads to some of its side effects. So with sympathetic blocks, they're typically guided by imaging. Oftentimes I see it by CT guided, and it's a 2-step process. The first one is a prognostic or therapeutic nerve block where you have an anesthetic, usually bupivacaine or ropivacaine, and a steroid, which is typically Decadron. And so that block, first one is used to say, is this going to work? Is it effective? And these are often done in our institution by interventional radiology, but there's a lot of other pain specialists that can do this. So it's not limited to that type of team. So this block, if it's effective, can last 8 to 12 hours. It depends on how long the bupivacaine lasts. And then the patients can also get a prolonged effect if you have a steroid, and that steroid can sometimes start to kick in 2 to 3 days, and it can last weeks after that, days to weeks. So if someone has a prolonged effect, it's because of the steroid. But they may just get that short, just hours of block. So if you are seeing this patient in the hospital, you're around the next day and their pain's back, make sure you ask them, how was that pain? How was your pain control for that first 4 to 6 hours after your pain block? And it may be very different than how they are that day. The interventional radiology team will call the patient and also ask these kind of questions within 24 or 48 hours just to get an idea. And a successful block, prognostic or therapeutic block, is if the pain's improved by 50% or more. So if it is successful, then they will move on to a therapeutic neurolysis. And this is more permanent block. Sometimes it needs to be repeated, but personally, I've not seen one need to be repeated so far. And it could be our patients' life expectancies too, that's going to play with that. So the neurolysis can be a chemical neurolysis with very strong alcohol, 100% alcohol or phenol, or it could be thermal with radiofrequency or ablation or cryoablation. So the risks with neurolysis, you're really trying to destroy the afferent neural pathways involved with pain transmission, but also trying not to destroy any other surrounding tissue, which can be tricky. Sometimes the block worked, but then the ablation didn't, and you're like, why would that happen? And talking to our proceduralist, sometimes it's just harder to get that alcohol right where you want it, and it just, drains around. It doesn't just quite get in the right spot. So that's what could be happening if one works, but the second ablation doesn't. Uh, so the goal is to try to preserve sensory and motor function while just blocking the neuro like pain pathways. So risks are neuritis, sometimes nerve regeneration causing recurrent pain. Sometimes people need a repeat ablation. So I like this diagram more because it shows where these blocks are in different levels. We'll go into more detail, but the ones, and this, as you could see, it's a European figure, the way they spell celiac plexus, but the main ones that we'll be talking about, I've circled here, the celiac, the hypogastric, and impar blocks. So starting at the highest one, and this is the one you probably have heard about the most, is the celiac plexus block. This could very well be on the boards. It's probably the most common. So I would definitely note this one. Celiac plexus, the block is used for upper abdominal malignancies, often that are associated with visceral pain. This celiac plexus receives pain fibers from the splenic nerves, innervating all the way from the distal third of the esophagus all the way to the small bowel, and the colon up to the mid-transverse colon. So that's a lot of areas. If you can see listed here, that could be potentially covered with the celiac plexus block. So it's not just for pancreatic cancer. So some of the thing is at the level of T12L1. It's a pretty high success rate compared to other sympathetic blocks. The quality of life in studies is improved in 65 to 85% of patients. And you get partial to complete relief in 90%, up to 90% of patients for 3 months, and 70 to 90% beyond 3 months. So you get higher success rate, high value per risk. The risk of more serious complications is less than 2%. And the other thing to know about it is if it's performed earlier, it's better because if, so let's say, a pancreatic cancer starts to spread, it just gets harder for the procedurals to get the 100% alcohol right where they need to go, and it's just harder to get the procedure done. So evidence is 1A, so very high and very good evidence for pancreatic cancer with moderate to severe pain that's refractory to analgesics, or I'd say if they can't, maybe they just don't tolerate opioids, then just do this procedure early. The other important part I put down here in the bottom in red is that if a lot of these patients with pancreatic or upper GI cancers are followed by GI, they're getting ERCPs or getting procedures, GI can also perform this block. And what I think is great when GI does it is that they can do the block and ablation at the same time. They tend to just do it both together, and they do it endoscopically. So they're really right there. They have less to go through to get there. And I'm going to show you here, if they go through a CT guided, you can see if they go from a posterior approach. Let's see if you can see my mouse here. It's going through so the posterior approach here by the spine. We're right by the aorta. You can see the celiac plexus is right over the aorta. So tricky place, little risk there. Anterior approach is seen in the CT image, and you can just see all the areas you have to go through. So, I mean, going endoscopically makes a lot of sense. So you can always message their GI physician if they do this procedure. Maybe it could be done at the same time as something else. So let's see here. And they see in these images, you're seeing them putting in dye because they first test to make sure they're in the right spot before they do the ablation or the block. All right. And so side effects can be diarrhea, and that can be from unopposed parasympathetic activity. It's usually transient. better in 2 to 5 days. You can also get some orthostatic hypotension that's transient too, and then more rare side effects of injury to anything that could get damaged during the procedure. So remember, these are malignancies of the upper abdomen with visceral component of the pain. So if the celiac plexus block is not effective, it could just be they're not able to get to the right spot because of where the tumor is. The splanchnic nerve plexus area is a little bit posterior and superior. And so it's just close, but just a slightly different spot. So if the celiac plexus block doesn't work, you can ask your interventional team, could you try a splanchnic nerve block? I found sometimes that they don't automatically say, oh, let's try this. Sometimes they do, but sometimes it takes us saying, could you try this? So that's why I think having familiarity with what's out there is helpful. But I rarely see this as the first block. It's usually, if celiac plexus doesn't work, then try the splanchnic nerve block. And the same thing, it's more of a block plus ablation. And evidence is 1B. For cancer-related pain, especially due to pancreatic body and tail cancer. I have seen also, not just with pancreatic or upper GI cancer, upper abdominal cancers, but also sometimes in cases of chronic pancreatitis, I've seen the celiac plexus block be effective. So now we're going to move down to the next level, and that's a superior hypogastric block. So consider this for intractable visceral pain from pelvic and lower abdominal cancers. So the superior hypogastric plexus is located on the anterior surface of the aorta still, and it's at the level of L5S1. So it innervates from the descending colon, so where we left off with the celiac plexus block, all the way to the rectum. There's uterus, bladder, prostate. And so just remember with this that it only helps with visceral pain. So a lot of patients who have, let's say, ovarian cancer or rectal cancer, the cancer has invaded all sorts of areas. So it's not just the intestines and retroperitoneal lymphadenopathy. So if it's into the muscles or bony areas, that the block won't help that pain. So they may need this block plus some other things in order to get good pain control. There's mixed results with this. Sometimes it works, sometimes it doesn't. About 50 to 70% of patients achieve good pain control. And why is that? I think it's just harder to get to the exact spot. There's more factors with these when cancer is in these areas. There's just a lot of cross innervation, so a lot of, again, visceral and non-visceral types of pain. So the evidence is 2B. So it can be used for a pelvic pain that's refractory to medical management. And similar risks with other sympathetic blocks that you see. You could have the diarrhea, orthostatic hypotension, and again, injury to anywhere around that you may puncture while going to that spot. Here is a CT guided on this image here on the left posterior approach, and how they would try to access that superior hypogastric ganglion area. This is this image showing just putting in some dye to see if they're in the right spot. So they use fluoro, they use CT for these procedures. All right, moving down further, ganglion impar block. So I've heard the term, consider this one when you're near the orifices, sort of the perineal area. So consider for cancer of the lower rectum, the anus, distal third of the vagina, rectourethral fistulas, radiation proctitis, and intractable perineal pain or that wound pain. That's where the impar block can be most effective. It's a solitary unpaired retroperineal structure, so with the end of the two sympathetic chains. And again, that visceral pain and those areas, and I sort of listed again those areas of the body where it can be most effective in treating pain. Similar to the hypogastric block, a little bit more mixed results with maybe not as high as a success rate as a celiac plexus block, but definitely worth considering if someone has intractable perineal cancer-related pain, and its evidence level is 3B. And so I'm showing you sort of where this is located. Almost looks like it's a little easier compared to the others to locate where it is. And here's good on this side, showing that how they inject the dye to see where they're going. So I'm going to pull in a peripheral nerve block here just because I want to compare the two. Because sometimes people say, well, when would you use a pudendal nerve block versus a ganglion impar block? So when talking to proceduralists, what they've told me what was most effective for the, if you have more superficial or anterior pain, then the pudendal block is the best. If you have more deeper, more posterior pain, then a ganglion impar block is better. And sometimes you need both. Like I said, there are a lot of mixed nerve innervation down there. And so sometimes it is both. And they try one, or maybe they try both at the same time. So going back again to the sympathetic blocks, there's something called the lumbar sympathetic block. And every time I give this lecture, I always like, oh man, I should be thinking about this one more often. So the lumbar sympathetic chain is paired ganglia anterior lateral to L2 to L4 vertebral bodies, and it gives that sympathetic innervation to the lower extremities. So we want to consider this one if we have invasive tumors around the lumbar plexus itself or tissues around that area, phantom limb pain, stump pain. That's one's really hard to control sometimes with medication. Peripheral vascular vasospastic disease of the lower extremity, groin or testicular pain, or lumbosacral neuropathies, and even tumor-related bladder spasms. So some interesting, probably do the sympathetic part, side effects. Sometimes people have hypotension, but some people have different temperatures of the leg. There's also genitofemoral neuralgia that could be a side effect. So that is the summary of the sympathetic blocks. So we're going to move into peripheral nerve blocks, unless there's any questions so far on sympathetic blocks. All right, so move on here. So peripheral nerve blocks, we're thinking somatic pain, more localized pain. And we know that, let me just go to the next slide here. So somatic pain within the distribution of a particular nerve or plexus, it can be used as a single injection, continuous infusion. There's less often that we're using ablation of peripheral nerves due to the risk of motor and sensory block and neuritis. There's just higher risk of neuritis with that. So you'll see it more again with the more short-term blocks. Let me see here. Let me go back. Okay, yeah, we'll just do this. We'll go to the next one. So this is a procedure to remember. I love intercostal blocks. I would remember this one for your boards in case it comes up. It's probably one of the more common ones I refer for in addition to the celiac plexus. So when can we use this? It can be used for lung or breast cancer with local extension. I guess I'm going to back up first. Where it helps is chest wall pain or parietal pleural pain. So anything in that area, it can be effective. So think lung and breast cancer with local extension, metastases to the chest wall and ribs, rib fractures, chest wall trauma, postherpetic neuralgia, any kind of thoracotomy, post-thoracotomy, mastectomy syndromes, and chest wall wounds. So those are just some of the things to think about. So I'll have even someone with a lung cancer that's you could just it's just pressing near the pleura, and they just have such bad pain, and you think, is that too deep? If it's affecting the parietal pleura, this can be very effective. So it's either ultrasound or fluoro guided. It's a two-step process similar to our ganglion blocks, where you have the test dose and then you do the ablation later. And so the test doses with bupivacaine plus or minus a steroid, usually the Decadron, and the risk of infection, bleeding, pneumothorax. The risk of pneumothorax is about 1% per level done, and they can do more than one intercostal level at a time. So there's the images I have here from a case where there's a young woman who was she had breast cancer, mastectomy, wound, severe wound, was at home. She had young kids. She had to do maybe twice daily dressing changes, was screaming, crying out in pain every time with the dressing change. She ended up having an four-level intercostal nerve block, and that's the upper image that's showing the nerve block, and they're injecting the dye to make sure they're in the right spot here under the ribs. And then was followed up, and she had 3 weeks of pain relief just from that. So that steroid must have really helped. And then cryoablation is the bottom image here, cryoablation of the nerves. And that you can see the ice ball forming here from the cryoablation. And she had months of pain, and I'm not sure what happened after that, but I know she did very well after that and tolerated really that whole chest wall side was numb. So the pain was gone on that side. So it's extremely effective. So highly effective. We said pain from the chest wall or pleura. Consider this one early. We don't have to wait till they're on high opioids or exhaust all options. Consider this one early. Um, yeah, move on. So there is an option for peripheral nerve blocks to do local infusions of an infusion of a local anesthetic. At our institution, these procedures are done by our anesthesia pain service, or sort of an arm of the anesthesia team that does epidurals and blocks before surgeries, and they get called in to do these type of things. So for example, there may be a patient with rib fractures that has a lot of pain or can't tolerate opioids or post-thoracotomy pain. So with these different devices, and I have no ties to anything, I'm just going to show you pictures so you have an idea of the different ones our institutions has used. It used to be the OnQ pump, and now we use this ambit pump, but the concept is the same, where you have a portable infusion device delivering continuous flow of local anesthetic close to the nerve or nerve area. And it's at a programmed rate. So you can either have, continuous infusion, you can have continuous plus boluses that the patient can push, or just boluses. And some people who have just incidental pain may just want the bolus. It's inserted under ultrasound guidance. Ropivacaine's one of the more commonly used medications for this. An example, and it stays in for about 5 to 7 days. I know at least for the OnQ pump that we had, that bulb would be filled with the local anesthetic, and that would last about 2 to 3 days, and it could be exchanged. People can be discharged with this pump and they are taught how to remove it. So again, short term, but can help get people through a pain hump, whether it's in the hospital, getting through a surgery, or maybe as a waiting for that interventional procedure that they're going to get. One example is a serratus catheter for unilateral rib fractures. So typically, if you're calling an anesthesia pain service, if that's what you have at your institution, they'll know which type they want to do. We just say chest wall pain. Can you see if there's a nerve block or an infusion, on a nerve block infusion pump that they could benefit from? And they'll think of all the different options and decide where. But just wanted you to know that is an option. So when I talk to the anesthesia service, they say this serratus catheter block is good for unilateral chest wall pain. If someone has bilateral chest wall pain, then an epidural typically works pretty good. Another way to block the area is an erector spinae plane catheter, where they go they deposit local anesthetic into a fascial plane deep to the erector spinae muscle, and it blocks those ventral and dorsal rami of the spinal nerve. So that can provide good relief for thoracic wall pain. They can also use it for upper abdominal pain too, if they go at a little bit of a lower level. Another great one to consider that's easy, can be done by ED physicians, is a fascia iliaca compartment block, or there's femoral nerve blocks. So if you have a patient with a hip fracture, maybe it's someone who was on hospice, they fell, broke their hip, they want to go to the ER, get checked out. Not sure if they want surgery or not, or maybe they won't tolerate surgery. The least we can do is block their pain. And I know this won't last forever, but it could be at least temporary pain block with this type of fascia iliac compartment block. So you don't need to necessarily remember that name. Just say, can you do a pain block while my patient's in the ED? And they usually know what that means. They do it ultrasound guided. Sometimes if we want something to last longer than that initial block, that's when an anesthesia pain service could thread in one of those catheters. So then you can maybe have 5 to 7 days of pain relief and just get through the most painful hump, whether it's pre-op, post-op, or maybe they don't want surgery and it gives you some pain relief for at least some period of time. There's a break. You can block the brachial plexus in a lot of different areas. You can see lots of nerves. Depending where you block, determines where you get the relief. So I've never seen an ablation of this area because there's a risk of motor sensory blockade. So less often I see this actually used, but it's an option to consider. All right, now we're going to move on to cancer-related bone pain. And we know that cancer-related bone pain can be very common in metastatic disease. The pain is from periosteal tumor infiltration, inflammation, mass effect on the structures. It can lead to instability, fracture. We know that radiation therapy and drugs can inhibit, there's radiation therapy, and then we have medications that inhibit osteoclasts, and they can also reduce adverse skeletal events. Radiation can sometimes, though, take 3 to 4 weeks to start seeing the pain relief. So when I've talked to our radiation oncologists and I talked to our proceduralists, I think of interventional procedures and what's the timing? When should we do an interventional procedure for pain first versus radiation? And oftentimes I'm hearing them say, really consider the interventional procedures early because they have the more immediate pain relief. And I'll show a slide about that. Next, when we talk about especially metastatic disease to the spine, we have the procedures that we commonly hear about is vertebroplasties and balloon kyphoplasties. So those are ones that often they're recommending do these first and then later, 1 to 3 weeks later after wound healing, then do the radiation because you get a little bit more immediate pain relief and then get the radiation afterwards. This is another one I would highly recommend remembering these vertebroplasty, kyphoplasty, because the evidence is 1A for these, for patients symptomatic vertebral compression fractures from spinal mets. And that also could be a board question. So you'll also hear about radiofrequency ablation and cement, like putting cement stabilization, also known as cementoplasty. So that could be in the spine, or it could be really in any weight-bearing bone. So it could be in the pelvic bones, lower extremities, so any weight-bearing bone. So the radiofrequency ablation, or there could be cryoablation, that's where we're trying to so I get my notes, to destroy that unhealthy tissue. It can actually reduce the tumor size. It can inhibit osteoclast activity and destroy periosteal nociceptors while sparing, and the goal is to spare the healthy tissue. So that's how the ablation can be helpful. I think it's really that cement that stabilizes and causes the most immediate pain relief, because once that's all stabilized, it's almost like putting a brace on your fractured bone. It's just more stable. So very effective. So if you have any painful lesion in a bone, especially weight bearing, you can reach out to your interventional team to see if there's anything they can offer. And so that the evidence is 2 to be for the radiofrequency ablation and cementoplasty. So, going to give a case. One case I'll always remember is we had a 67-year-old female with newly diagnosed parotid gland adenocarcinoma with metastatic disease involving L5. She had sacral pathologic fractures, and she had been for weeks limited to the prone position, just laying on her stomach, couldn't do anything, almost at the point of asking for a cordotomy, just miserable. And she had to escalate her pain medications. She had just piercing pain. We ended up doing an L5 radiofrequency ablation with kyphoplasty, and also to that sacral fractures ablation plus cementoplasty. And she went from that prone position to the day after the procedure. I came around on her. She was sitting on the edge of her bed smiling. And I was like, what room did I just walk into? And then the next day was able to work with therapy. So just a complete 180 turn. And it's very quick turnaround with this procedure, with these procedures. So just show some of the images. This is her spine before. She ended up having the kyphoplasty. This is the balloons inflating. Then they put the cement in where the balloons were inflated. And then there's sacral fractures where these probes are showing where they do the ablation. And then they put the cement to stabilize. So just wanted to just highlight that because I've again seen a lot of great success with those procedures. Okay, so now we're going to talk about a little bit about lumbar pain. I'm talking about this a little bit. Sometimes it's cancer related, but honestly, our patients have more than their cancer related pain. We sort of take it all when we're managing pain. They could have degenerative disc disease on top of their cancer related pain. So I'm going to mention some things that could be used for, non-cancer pain too. So epidural steroid injections are pretty common, a commonly used procedure for degenerative disc disease, pain in the central midline spine area, or it can be continued pain after a vertebroplasty or pathologic vertebral fracture pain that's not amendable to vertebroplasty. So it can be given up to 3 injections at intervals no less than a month apart, so it can be repeated. And usually it's a decadron that's used. And so risks are low. And so I find that if the pain's more midline or bilateral, this is when the epidural steroid injection is often used by our interventional teams. If someone has more unilateral radicular pain, they tend to do a selective nerve root block where they're blocking the spinal nerves on one of the sides. And you can have up to several months of pain relief with these, and they can be repeated. Medial branch blocks can be helpful for pain related to osteoarthritis of facet joints, pain with this lateral movements or spine extension. So it's the local anesthetic to the medial branch of the dorsal ramus. And usually there's a lot of insurance driving this, is a 2-step process where they do 1 to 3 diagnostic blocks under fluoro. And if they're successful, then they can get the approval by insurance to go to the ablation. So people have pretty good pain relief up to 70%. Patients show improvement for at least 6 to 12 months. All right, so now we're going to move on to central neuraxial blocks in infusions. And we know that the dorsal horn of the spinal cord is rich with opioid mu receptors, and neuraxial analgesia allows medications to bypass the systemic circulation and limits GI absorption so that we have less side effects and can use much, much smaller doses. So we are showing here some images of where our spaces are, the epidural space, the intrathecal space, and just another side view here, entering those spaces. So we're going to talk about epidurals and maybe when would we consider these in our practice. So epidural compared to intrathecal delivery, there's higher fluid volume that's needed for epidurals. There's risk of respiratory depression, urinary retention. So a lot of times patients will have a Foley or may need Flomax. You can have orthostatic hypotension. Also, you could get motor blockade. The duration, 7 to 10 days. So this is a short term. Whenever I would consult anesthesia pain, they like to know the big picture plan. So if it's only going to be in for 7 to 10 days, we aren't necessarily doing it as someone who we want to get home and we don't have anything that's going to fix necessarily the pain in that 7 to 10 days. So it's helpful for post-operative pain, maybe a major thoracic or abdominal surgery with uncontrolled pain. That could be an indication. I've had several comfort care patients that have benefited. For example, we had a patient who had a GIST tumor, maybe a small bowel obstruction. We were having to escalate opioid infusions on comfort care. But he really wanted to wait for his son to come in town to say goodbye, who was coming back from college. And so we ended up having an epidural placed, and we were able to go down on his opioid infusions. And he was able to be alert and have that quality time that he was hoping for with his son. So that's an example of how it could be used in an inpatient setting in comfort care. Now they're getting more sophisticated. There's the epidurals with the PCA. So just like a PCA pump, general PCA pump, they can have one with the epidural. So they push a button and they get a bolus into their epidural. And that's all run and controlled by anesthesia. As far as dose equivalencies, this is approximately what the equivalencies are. So if you have 10 milligrams of IV morphine, that would be about 1 milligram of epidural or 0.1 milligrams of intrathecal morphine. So moving on here, intrathecal. So medications here delivered to the intrathecal space, a lower volume is needed. You can use morphine, hydromorphone. A lot of adjuncts can be used in them as well, like bupivacaine or clonidine. Clonidine is often for patients with spasticity, it's used often in kids with spasticity. Benefits: decrease opioid use, decrease peripheral side effects. Depending on where the level of the pain is, determines where they place that catheter tip. And there's some various risks, including spinal headaches, epidural hematomas, infection, catheter migration, or catheter tip granuloma, but that's pretty low risk. What's the hardest thing about intrathecal pumps is that there's just sometimes a long process in multiple steps to get to that point. And what I found, at least in our community, is having one provider who does all of those steps. We really don't have that right now. So it's finding first, if you think someone's maybe a candidate, talking with someone who will manage the pump. And if they say, yeah, I think this would be great, I would be happy to manage it once it's in. Then we go to a proceduralist. For us, it may be our interventional team, and say, can you do a test dose? Then they do a test dose of morphine or Dilaudid. And if there's a 50% reduction in pain, it's considered it worked. And then they would go on to planning with a neurosurgeon, for example, an implantation of an intrathecal pump. Then to go back to the person who manages the pump. So I think our biggest barrier is the logistics of it. But if you look at the literature, it's effective. We really should be considering it earlier for patients with chronic or refractory pain or are unable to tolerate opioid escalation. I think oftentimes the patients that we are referring, it's almost too late because maybe their life expectancy is shorter at this point or their OMEs are very, very high. I think it gets harder to convert from, let's say, 500 plus OMEs and then get into an intrathecal pump and try to build up to a good pain control. It's a lot harder when they're very high OMEs. So consider intrathecal pump and the referral process if someone has refractory pain, if their OMEs are over 200, start to think about it. If they have intolerance of systemic medications, If think about if their life expectancy is over 3 months. If it's less than 3 months, then insurance wouldn't cover that. And it is a upfront cost, higher cost, but there's cost equivalence compared to traditional pain management at around 7.5 months. And just some images of where it's located. Maybe on a future in-person lecture, I have a little pump. I could hand to people that they can see how big it is, how heavy it is, and it gets usually planted in a little pocket in the lower abdomen, and refills every 1 to 3 months, depending on how big their pump is and how fast they're going through their medications. All right, spinal cord stimulators. So spinal cord stimulators, there's delivery of electrical stimulation to the dorsal epidural space, trying to inhibit that sensation of pain. We usually start, this is a trial first, where the leads are connected to an external pulse generator. This is often done by different pain teams in the community. It doesn't have to be an interventional radiology team. Different complications you see listed there: lead fracture, migration. This is really, the spinal cord stimulators are helpful when you have someone with neuropathic origin of pain. It's focal, there's a certain place. If they have just pain all over, in general, hard to describe pain, it usually doesn't work well. So if they have focal neuropathic pain, when conventional therapies are ineffective, so think of like radicular pain syndromes, chemo or radiation-induced neuropathy that's not responding to medications, CRPS, any post-thoracotomy or pain syndromes or phantom pain. The evidence is level 2, and there's an extra 3 there, C for refractory cancer pain and 3C for chemo-induced peripheral neuropathy. I've had patients who've gone through different things. Let's just say they had a thoracotomy. Initially, post-op, they were on an epidural, and maybe you're like, okay, this is going to be a little more long-term. They may do intercostal block and ablation. And if it's like months and it's still ongoing, something that can be considered next is spinal cord stimulator to help with that just chronic pain from a post-thoracotomy kind of situation. So you may see multiple of these procedures used over time for the same patient. All right. So here's just an example where we combine some different procedures and see what helped. So we had a 56-year-old with metastatic rectal carcinoma with surgery, chemo, radiation, decided to stop treatment. Pain was on the ribs due to METs, and also had some growing pelvis pain due to lymphadenopathy in the retroperitoneum. So the patient had an effective intercostal nerve block, and then followed by ablation for sort of that T6, 7, 8 area. He then had a left lumbar sympathetic nerve block. That was not effective. So then they tried a spinal cord stimulator trial, which led to 70% pain relief, and then moved forward with the implantation 6 days later. And that was very effective. So this shows how sometimes it's just a stepwise process. And then lastly, just wanted to show a few different neurodestructive procedures. This is another area I just forget until I give this lecture to refer to neurospine surgery. There are neurospine surgeons who have a practice that's more dedicated to pain procedures. These procedures disrupt pain pathways in the spinal cord to provide relief in patients. This is often, those with limited life expectancy, or when other procedures didn't work, or we have limitations to medications. So one is percutaneous chordotomy. Evidence level is 2B, where there's radio frequency lesion created in the lateral spinal thalamic tract and you do it on the contralateral side. It's bringing me back to med school. I'm sure Joel has all over and understands these tracks very well. It's CT or fluoro guided. So yeah, it's used for unilateral nociceptive cancer pain after failure of more conservative options. Another one is a punctate midline myelotomy. That's the middle picture here. And that's evidence level 3C for midline visceral pain. So if we go back in the lecture to where we talked about maybe you have ovarian cancer or pelvic cancer, and you tried the hypogastric ganglion block, and that was not effective, or impar block. This is one additional step you could take is referral to neurosurgery for a punctate midline myelotomy, because that could be helpful for these patients. Next is drazotomy procedures. Evidence is not as good. There's an evidence level 3I, so for insufficient, where there's destruction of the central dorsal roots and horns for neuropathic malignant pain. So again, when all else fails, this is something that could be considered. So to wrap it up here, some take-home points is consider interventional procedures for intractable pain in your palliative patients. These procedures can provide pain relief, decrease opioid requirements, decrease medication side effects, improve function and quality of life. I've been asked in the past to share, how do we contact some of these procedures that you are talking about? For those who are living locally here, there's our interventional radiology team. We have a coral spine and pain clinic that does spinal cord stimulators and other just general pain procedures. They even do like plexus blocks and other things like that as well. And then independent group, Haven Spine and Pain. They really do a whole patient care for the whole patient, medications and procedures. There are two anesthesiologists who run that practice. And they often are where we refer patients who have maybe graduated from our palliative care clinics and need ongoing management and pain procedures, blocks, things like that. All right. And just if you're looking for a good book that talks about pain, all different pain procedures, this is one I'd recommend, or maybe a little library in your fellowship office. It has different algorithms for based on where your pain is, different blocks you can consider. So it's just full of good information. So just wanted to give you a sneak peek at the book if you're interested in learning more. And then I have some references, and we'll make sure you guys have a copy of the slides for reference. So just want to ask if there's any questions that people have or anything they want to share, their experiences.
Hey Gretchen, I have a quick question. I know that we talked about you do the initial like kind of like test block and that works, and then sometimes the second like the ablation block doesn't work. Are they willing to usually like try again if for some reason it doesn't work, or is it kind of like a one-time shot situation?
Yeah, great question. If they think they've got to the area well, they may not try it again and say, yeah, we're going to have to think about another option, or it's just not going to work. Sometimes they're like, yeah, you know what, we just couldn't quite get to the right spot. We'll try it again. So it's worth asking, especially if the block worked and the ablation didn't. I often ask that question, and sometimes they are willing to try again if the patient's willing to try again. So yeah, you can definitely reach out.
Thanks.
Mm-hmm.
Oh, yeah. Gretchen, I had a question about the case you presented about the gentleman with the metastatic cancer. With him getting eventually the actual pump place, like, the implanted one, right?
Mhm.
That's how it ended? I mean, what was his prognosis with all
The
that?
the one who had the spinal cord stimulator.
Oh, yeah, sorry, spinal cord
Yes,
stimulator. I said pump,
yes.
but
He ended up It was one of my colleagues' patients, and he ended up dying within a couple months. And I don't think they expected that.
I guess what I'm surprised about I guess, how was that not expected given his degree? I mean, I just feel like so many of these patients who need this
Yeah.
level of pain control, kind of like the
Mhm.
greater than 200, MMEs, like it's because they have, pretty
Progress. Yeah.
progressive disease and
Right.
diffuse metastatic, that like the likelihood that they're gonna, like for the one was like greater than 7 months, or like even for something like that, it just seems like
Mhm.
a really big financial resource use, for something that, not to say they're not worth it, I don't ever mean, but just when we're
Yeah.
talking about like technology and things that are implanted, it seems like a little bit, I don't know, counterintuitive or.
Yeah, it's a great point. And I think that they also can do external, just keep it external. I mean, some people are just so miserable. I think
Yeah,
when you're
sure.
seeing them in clinic, it's really hard to be like, well, just keep going on the opiates. And there's these people who are like, they don't want hospice and they're just
Oh,
like, keep going. And you're just like, okay, well, we can try this. So I think too, it's really hard in the moment when you're trying to do everything. So I think we do find ourselves in that situation. You're like, wow, they finally get pain relief and then are comfortable and
yeah.
they die. The lady who was prone and had all those procedures
Oh,
and was
yeah.
walking that day, she discharged to Trillium Woods and she was much better, but she's like, I'm ready for hospice now. Like and so,
Sure. Yeah. Okay.
and yeah, so I think I don't know. If I can relieve someone's pain,
Oh, yeah.
even if it
No, I
gives
get
them
it.
a month,
Yeah.
to me, that may be worth it. But we have to discuss those risk benefits with them. But intrathecal pumps, for sure, the insurance definitely doesn't, they will ask you their prognosis.
Well, right. And I would
Mm.
think, I guess I would anticipate
Yeah.
insurance pushback on a gentleman with
Yeah.
that,
Yeah.
like even for the spinal stimulation. I'm just surprised that it was covered or whatever. So,
Mhm. Yes. Me too.
Yeah, and when we've run into that at Trinity as well, Gretchen, you alluded to it, the prognosis. Um, Often insurance wants at least a 3-month prognosis. They want to see that you can get that benefit for at least that long. It doesn't mean it's going to happen, but they do factor that in.
Mhm. Yeah. Any other questions, or has anyone ever had any other procedures that they found really effective in their patients? That, I mean, there's so many we could talk about, try to limit to what we can fit in this time period, but welcome anyone else to share their experiences.
I have two questions. One is, are all of these done by like interventional type people? Like, that's not something we can do, maybe with the exception of Bruce, but
Mhm.
is it all done by interventionalists? And secondly, do you feel like this is an underutilized, um, intervention, for lack of a better word?
Mhm. Yes, I do think it's underutilized because if we're not thinking about it, we won't place the referral. And so it's it's more we have to think about it. And then again, the proceduralists can often choose, well, what procedure. But if we're not even giving that option, then it's a missed opportunity. So yes, I think we could be using it more often and earlier. And I think that right now our team doesn't do any procedures, even though we have people who are EM trained, or you have an anesthesiologist on your fellowship team. There's interest, but it's trying to make sure if we have a whole practice, something happens. We have our whole team really needs to be familiar, and
I
so it's
see.
hard to have
I
one
see.
person who can do ultrasound guided blocks or this or that. So it's just hard to make it a robust service. But yes, I
Yes.
think that in the future, if you had a team, you could do ultrasound guided blocks or some of the things that the anesthesia pain service does. But otherwise, a lot of these procedures are image guided. And so that's why they're done by interventional radiology or pain. There's anesthesia has pain fellowships that a lot of the ones that are doing it, like Haven Spine and Pain, they're trained in pain procedures.
And are they pretty responsive? I mean, like if you order it, usually do it. I mean, with the exception of insurance, are they pretty like,
Mhm.
yeah, I think, yeah, we'll do this.
Yeah, what we've found helpful is we've developed a relationship with our local, our proceduralist. So even just having one key person
Yeah.
from an interventional team or from your pain team, and we place referrals, but sometimes we message them and say, hey, I have this case. And they know palliative care patients need more urgent appointments. And so we try to work through that and work through barriers. And honestly, these patients give them high satisfaction. They love doing procedures for palliative care patients or hospice patients in some cases. And so they will try to get them in quicker. But it sometimes takes that discussion and extra communication.
And I just wanted to say one more thing. I was not aware of intercostal blocks, and it's funny that that came up because I just had a patient who now has a new diagnosis of lung cancer in the hospital, but was receiving intercostal blocks through a pain clinic for a prior MVA, and she's been getting them for like a while, and then developed a large lung mass on that side, and was kind of like, how do they not catch it? And I was like, well, it's different imaging. And we really didn't talk about using it for the lung cancer, and the question sort of becomes, where did her pain, like the overlap, which of it is the car accident, which of it is the lung cancer? But now I've had two women with metastatic, electively not treated cancer type of situation, went the non-medical pathway and ended up with these fungating, eroding masses of the skin. And the pain, like you mentioned, for the dressing changes and just even just being there is so high, that like using an intercostal for that, I hadn't even like really thought of that as an option. So those cases are unfortunately more common, I think, than
Yeah,
we would imagine they would be. So
yeah, great example.
Thank you, Gretchen.
Yeah, thanks everyone.
Yeah, thank you, Gretchen. One last question for you. Maybe I missed it, but did you mention the stellate ganglion this year?
I haven't, I took it out. I think I've taken it out. I can. Have you used it? I think it's because there's a stellate ganglion and our procedurals have, I don't think I've ever seen it actually done. But maybe I'll add it back. What, have you used it, Joel?
Well,
And
I've
how do you
used it
find it?
once on one patient, and she had ocular, like global ocular pain. And she
Ooh.
had history of a Pancoast tumor, so we were able to use the stellate ganglion to block it, and she would get 3 to 6 months of pain relief
Ah,
just doing that. So head and neck pain, it's good to consider that stellate ganglion as well.
yes, good. Well, I'll add it back. I had too many blocks at one point in my lecture, so I had to narrow it down, but I'll add that one back and glad that you had a good example for that one.